In the academy, we are not sleeping. We just react to that. It is a pity to see that the teaching of echography and ultrasound is fundamental for all the surgeons.
This is, we recently orthopedic surgeons who do echography for hand surgery, urologists, liver surgeons, but it's not the case for most surgeons in France.
Thank you. Your second topic, you can go on, please, to present your second topic about arterial echographic guiding interventions.
That's supposed to be my first, but here we are.
Perhaps you can comment directly live. Live comment is preferable.
Okay, so let me see if I can share screen here, my presentation. Is that okay?
Okay.
Let me see if I can limb salvage. Here we go. Okay. And now I go here. Okay, now. All right. Can you hear me?
Yes.
All right. So today I'm going to share with you some of the techniques that I developed out of, as I call it, out of desperation. I didn't plan it, but I saw the problem and, you know, and I couldn't do anything but do an amputation. I said, what else can I do? And then some ideas came to me and I tried them. Interesting, and I have no conflict of interest with this presentation. Well, let's give credit, first of all, to Professor Conlin. John Conlin was a great surgeon. I'm sorry I did not have a chance to meet him personally, but I met Dr. Lengua, who had worked with him for many years. And he's the one who had the idea to do a bypass instead of just very long endarterectomies that people lost a lot of blood and the results were not so fantastic for the long lesions. So he basically developed the concept of a bypass surgery, and that's really not debatable. You can have interposition graft like a Russian fellow did in World War II, World War I, and we actually highlighted him. I did not know about the doctor from that just presented now an interposition case from 1912. I took notes of that. But then it took about about 2 decades for Dr. Macon in the United States to extend this concept of bypass to the popliteal down to the tibial vessels. But here we are. I had a patient, Mr. Smith, I can say his name, he doesn't mind at that time, where he came to me and he had nothing, no named arteries to do, except some branches in the foot. So I spoke to my colleagues and they say, no, if you do a bypass down to the foot, he's going to step on the foot. He won't be able to put a shoe, just do an amputation. I felt that some of these arteries, like the plantar arteries, were as big as the posterior tibia sometimes, especially when the posterior tibia was occluded, they were pretty developed. So I did a first bypass to the plantar artery and the patient did not step on the bypass, nothing happened really, and the foot was salvageable. So I started doing many cases and I published the first case 40 years after, which is incredible, 40 years. So vascular surgeons we are kind of slow to adapt some techniques and we still believe in dogmas and we don't challenge them enough. But we did that and was successful. Also, it was such a simple operation. Just go to the distal posterior tibial, transect the flexor retinaculum, and the vessel is right there. The superior branch is always the medial plantar artery, and the lower branch is the plantar artery that feeds the pedal arch connecting to the dorsalis pedis. So those are my 2 first cases, and the first that's been published. On your left, this was actually published in one of Frank V's paper as an example. That was my first case that I did to the lateral plantar artery with a short vein from the popliteal artery, and worked for years, this bypass, until I lost follow-up with the patient. And when the lateral plantar artery is occluded, like you see on your right here, I don't think so. You see my cursor? Yeah. Oh, okay, great. So here's occluded the lateral plantar, but the medial plantar was great. It became very large and had multiple branches. Didn't form a pedal arch, but was enough to save the patient's leg. So those are very simple procedures. And then I did one to the lateral torso and even down to the plantar arch by removing the second a portion of the second metatarsal bone and pulling out the flexor, the extensor to the first toe, and the artery was all the way deep. Interesting enough, although it was calcified proximally, distally, there was absolutely no calcium, and we were able to do a bypass. Here's the lateral tarsal artery, the first one, after this patient was transferred from another hospital, after multiple debridements and toe amputations, and with this short bypass as well, with vein, of course, always with vein, it worked very well. Now, if you're going to do this bypass to the branches of the tibial arteries, then the idea, what I noticed when I placed that bypass to a parent artery, trying to push the envelope and not to go into the branch, did not work because of turbulence. So we really have to go into the branch to place the tip of the bypass. So when we compare leg branches and foot branches, the leg branches did not do well. If you're going to get a branch of the anterior tibial into the leg, they all failed basically in 4 months. But the ones in the foot worked very well, 81% patency in 2 years. And the idea was that we had to use a short vein. Those are mostly done with short veins, which work better than long veins. But if you don't have, I still would do a long vein to the plantar artery. You have to have some skills, but it's not excessive skills. Just have to don't place 4 or 5 cases on the schedule that day. You really have to be dedicated to do everything to save this patient's leg. And this is just a comparison of our results between a long and short vein. Others have reproduced that many years after, showing that these bypasses are really an acceptable procedures. This is the group from Boston. Pomposelli is leading it. And remember, we did the first randomized study in vascular surgery with Frank Vieth leading it and 3 other institutions, John Bergen and Victor Bernhard. And we showed that PTFE bypasses were really miserable at 4 years, 12%. So people took this data and said, well, with this kind of data, we're going to amputate the leg. There's no purpose of doing this operation, reoperations every other day. And until today, people, when they don't find a good vein, they do an amputation. So is it really true? There's anything else we can do? So although a bypass such as this one, all the way from the external iliac to the anterior tibial, worked for 4 years, that I know, 5.5 years patency. But look at the tibial vessel. Beautiful, very large tibial vessel with a lot of branches. It's almost like a popliteal. It's not the common thing. Most of the cases, after 2 or 3 years, will be obstructing. So I learned from Herb Dardick, who passed away a couple of years ago, who's my friend. He told me that he does a fistula. He hooks the artery to the vein, and that improves the flow through the main portion of the graft, and they work very well. But if you see, he did that side-to-side anastomosis in a calcified vessel, which many of them are. It's not so easy to do the anastomosis. And also, the vein can expand with time, can become dilated. He said it was not his experience, but when I did some cases, I saw that with time, the vein was dilating significantly. So, but the concept was good. I like the idea of the concept. And the other one who developed a concept of putting an interposition vein between the plastic graft and the artery wasn't Dr. Miller, was actually Dr. Felix Sigmund, who was a general surgeon doing vascular surgery in my hospital at Maimonides Hospital. And when I spoke to him, he said, yeah, I reported that in SGNO as a case report, just to put it out there. Miller picked up the idea and he published a few series about it. And those 2 concepts between a cuff and a fistula were attractive to me. But nobody had proven actually that outflow resistance was a main cause of failure, at least until the 90s or the 80s when we start doing this work, because if you put a flow meter in a small vessel, it's not accurate. If there's calcification, the flow meter is also not active. So how are you going to prove that outflow resistance is a cause of graft failure? So just went through that. So I took the Ohm's law. It's a very simple thing, Ohm's law, and I knew that if I use the L'Hopital rule or the Bernoulli rule, that if I integrate both sides of the equation, the pressure and the flow, I would have something like this. Resistance equal to pressure over integral flow. By definition, integral flow is the volume that you inject. So I had to develop a computer to measure the integral pressure when I'm injecting some fluid into the bypass once I did the distal anastomosis. And for that, I had to reach out to a resident of mine at Albert Einstein, Dr. Lee Moran, who became afterwards the first surgeon, I'm saying the first medical doctor to go out of space and fix a robotic arm on the spaceship. So he's a very bright man. And he said, oh, you want to build this computer? I said, yes, I want to. He said, do you have $85? I said, I have $85 for you. And he built this little computer with $85. And we finally could then, oh, but before that, I told him, let's look at if our thought process is correct. So I went to the CIA because they have a very good mathematics department. And they told me, we cannot talk to you because you are not born in the United States. I said, oh, what can I do? So I went to another resident whose brother was working at the CIA, and she then was able to put through, and they said, yes, it's a concept that is correct. So we did the distal anastomosis, as you see here, and we injected from the proximal end of the graft 20 cc's of saline, and we measured the pressure that was generated by this computer while we injecting it. And we found that after 3 months, I'm sorry, that when the resistance was over 1.2 or equal to 1.2, all the PTFE grafts thrombosed, and below 1.2, they all remain patent. So then we had something there to say that alpha resistance was a cause of graft failure. Then we went ahead and we did some work in dogs to prove that with Dr. Caligaro, who is now going to be the president of the Society for Vascular Surgery in June. And it shows that with the fistula, with the fistula, the bypass stayed open longer than 1 year. So I wanted to combine both concepts into one operation, okay, which is now called the atrial fistula. So I took the best portion, the adjacent vein, the deep veins, I transected it, and I transposed it into the artery, as you see here. And we did an end-to-side anastomosis, not a side-to-side, but an end-to-side. And after that, I made a venotomy at the distal portion of the vein transposition, and I placed the PTFE. And if the pressure was not enough, meaning was not 100 millimeters of mercury pressure forward, I decided to bend the vein enough to create that pressure so I can get perfusion down to the foot. So now I had the interposition vein, I had a fistula and a controlled fistula. So that fistula also would never expand because I put the band without tightening it here around here if the pressure is good. Anyway, so it does not allow the vein to expand. Okay, just a quick movie showing you. Here's the anterior tibial. This is the anterior tibial vessel dissected and the vein adjacent. We're going to transect the vein a little bit more distally because it retracts. And we're going to do an end-to-side anastomosis. This is a very short video. As you see, everything is done on direct vision as well. And we open we do a venotomy, and we place the PTFE on top of the vein. It does not take any much longer than a regular bypass, really, maybe 20 minutes additional. And now we're proving with the completion angiogram that the flow goes distally. Now, many of these operations are redo operations. So how to speed them up? Instead of redissecting the groin in these cases and finding several grafts in there, or even one with a lot of scar tissue, with chances of injuring the surrounding artery, surrounding nerve and vein, we decided to make a small incision up just above the inguinal ligament, oblique incision, identify this virginal external iliac artery, and do a bypass right from there. Take the flow right from there, and use that other incision in the medial portion of the sartorius to do the tunneling. So that is a very easy procedure that takes 2 minutes, and you avoid completely all the complications that are associated with a redo groin in this patient that are often sick and old. And we increased the 26% at 3 years patency of PTFE bypasses without fistula, without nothing, to 48%. So I think, I'm sorry, to 55% I can see the number there, but it was over 50% for sure, with a limb salvage of over 70% in these patients. And other people have reproduced that procedures in Italy and in England and in some other places, and they all like the idea of having this vein interposition with a fistula. But you not always can do it. You need a good, at least 2 millimeters or more of an adjacent deep vein to be able to do this fistula. Now, what if you don't have anything like this one here? A little tiny vessel up in the foot and nothing else, and the patient has severe rest pain. So in this situation, rather than doing the amputation, I thought, why not do the following? I took the vein that the cardiac surgeon in that patient had forgotten to remove around the ankle. I transected it, like you see here. I ablated the valves distally with an antegrade valvulotome that I had designed, and I did a very gentle curve under the skin to the distal vessel that you saw in the angiogram, distal posterior tibial. And now I had retrograde flow into the foot and distally through the artery. And this was the first attempt, at least in North America, to revascularize the foot through the distal venous system. This was never done before. I didn't even know it existed, but Dr. Lengua came to visit me in Brooklyn, and unfortunately, I didn't have a chance to see him because I was stuck in a case that was very complicated, and he had to catch the plane. But he was the first one, Dr. Lengua here in Paris, the first one who did a retrograde bypass to the venous system for rest pain. And this is what you see. Completion angiogram, you have the bypass, the PGFE coming all the way from the external iliac vein artery down to the very small posterior tibial artery and the vein, interposition vein, and the gentle curve. Here you go. Distal flow through the venous system, as you see here, going all the way down to the foot. Okay, so I also did the following. The first retrograde arterialization in the distal venous system in North America. Now, that's with the deep veins, not the superficial veins. I anastomosed the peroneal artery to the peroneal vein. In this patient, he was 30 years and ready to retire as a doorman at Montefiore Hospital, where Dr. Viet was working at that time. And he was a very nice man. Everybody loved this guy. And he was booked for an amputation by a senior surgeon there. So I tried this crazy thing, and it did work. So 5 years later, he went in Jamaica, and he was walking his foot. I called Dr. Hamovici after the operation to come see the patient. He came running from the office. He put his stethoscope, and he said, wow, this actually does work. And the foot was warm, was nice, and he was very excited. Unfortunately, I didn't take any picture. I didn't think it was going to work anyway. So we published this in 1993. Okay, so let's go on. I don't know what this is. Okay. Now, what do you do in this situation here? You only have a segment of an artery, a distal anterior tibial, and an occluded dorsalis pedis, basically. Yet, I want to save this patient's leg. But I noticed one thing, that all the system was pretty good in this diabetic patient, all the way down to the distal peroneal. One branch was occluded, but the other one was patent, but nothing else. So what do? I decided to then transpose the anterior tibial onto the peroneal because there was nothing else I could do in this patient, no veins at all. So I took portion of the fibula, make one incision only, took a patient outside, excise part of the fibula, identify both vessels, peroneal and anterior tibial, and transpose the anterior tibial onto the peroneal, as you see here. And here's the completion angiogram. All right. Should we, I think we are above the time?
Yes. Yes, you are above the time. And can you conclude, please? Because we have some questions for you and a big announcement that I'm going to give you.
Okay, sure. So, okay, I'm just going to tell you about calcified vessels. When I used to speak to my senior surgeons, they are known all over the country, big shots. What do you do in a heavily calcified vessel? He said, we close the skin and we do an amputation. We crack those vessels openly. And if we need to, we use a towel clip and a rongeur to fix the vessel, to fix the calcification. Here you can see totally closed, rocked artery. and we use the clamp to partially clamp it to break the calcium. Okay, I'm gonna move to the other one. And then we use the rongeur sometimes to remove the calcium because it doesn't destroy the vessel. It just cuts the calcium wherever you want to. And then we place the stitches with some time. We take some time placing the stitches. But as long as you have a good lumen, this would work as good as if the vessel was not calcified. Okay, last thing. A patient was sent to me because a bypass closed 3 times and there's nothing they could do. They had done a fasciotomy on the leg. 4 quadrants did not work. So what happened? I measured the pressure in the foot and I found that the pressure was very high. So I did an ankle foot fasciotomy, have never been described before, and the bypass worked. Simple procedures. So thank you very much for your attention.
Thank you. Thank you very much. 1 or 2 questions only because we have to keep on time. Fabien, what do you think about this technique of superposition of the bypass onto the vein going to the distal artery? What do you think?
I mean, it's an elegant method on bringing together 2 different techniques. I use a slightly different one. I just anastomose one of the 2 veins that are available on the distal part of the artery, and this enhances the outflow of the bypass, and especially for PTFE bypasses. But I mean, it's exactly the same. It lowers the back pressure of the artery, and it enhances the probability that the bypass remain patent.
Ronald Virac?
Yeah, just to remind you that we have described the dorsal vein arterialization to the penis in 1979. It's exactly the same way of reasoning. And my question is, what is the difference with the Palma operation which was described prior to this? Is it the same or you have added something more?
Enrico?
Every time we think we add something more, we realize somebody else did it before. It's just a matter of just looking better in literature, in different languages. So I don't think we do anything different, anything original. Everything has been done before by other contributors to our specialty. So I don't know. There's several de Palma procedures. There's the venous de Palma procedure. Which one are you talking about? But if it's similar, I'm sure I give him the credit because I really don't believe that every time I study more, I found that somebody else did it before the person who says it did it.
Yes, it is not important, but we have to mention his work. He was a Peruvian surgeon, if I remember, or Chilean, I don't remember. And he described the arterialization of the venous foot. I don't remember exactly the year, but it was a long time ago. It was a model for me to do the arterialization of the venous system in the penis, which was exactly the same concept.
Yes.
Excellent point, but he's not Palma. This is Dr. Lengua, who I just mentioned twice before.
Enrico, the lesson we have to retain today is a Michael Debeke lesson. We have to go where the vessels go. It is the major lessons. It is very, and you are the perfect illustration of this application of this philosophy.
Thank you. Thank you very much.
Thank you so much. I give the word to Jean Jacques Busquet for very important information for you.
Okay.
Do you hear me? This is Jacques Busquet. Enrico?
Enrico?
I'm listening.
Okay, endorsed by the Bureau of the Academy of Surgery, we are glad and honored to invite you in 2026 to give a session of the Frank J. Vis International Society in Paris, in the Academy, if you accept.
With your wife in Paris, okay?
Thank you so much. Thank you so much. I'll make sure we'll.
Is it feasible? Do you accept?
If it's feasible, I'm honored, more so than accept. I'll be very honored. Thank you so much.
But no more wedding.
It is finished for you.
Thank you so much. Really a pleasure and an honor to be with all of you.
See you next May in New York.
Absolutely. We're looking forward to seeing you there.